Thank you very much. I'll be speaking in English. So first of all, thank you very much for inviting me to this really excellent conference, to excellent lectures. I learned a lot. And the previous lectures were actually a very nice introduction to my talk. First of all, I have to disclose that I'm a pediatric endocrinologist, not a geneticist. So I'm more inclined to make the diagnosis which is clinical, and then I'm very inclined to treat somebody when we make these diagnoses. And this is basically going to be the point of my presentation, that once we make the diagnosis, it's very important that then we can also offer somebody treatments, or we can discuss that there is, at the moment, no treatment available for this treatment, or that maybe in the future we can even develop treatments which could fit this patient, basically. So, as said previously, we're going to talk about short stature, severe short stature, which is, of course, a phenotypic feature, which we mostly see, of course, in children, but of course there are also a lot of adults which are undiagnosed and were probably not treated or not treated efficiently enough. So, who are people who are short stature? This is, of course, not for you to decide by yourself, but it's actually your height in children dependent on your gender and in your age, if it is below 2 standard deviations below the mean of the population. And the severe short stature usually is defined even by 3 standard deviations. So we're talking about people who are well below, for women well below 150 or men well below 165. And in some of the cases, of course, this short stature is very extreme, especially in the skeletal dysplasias. These final heights are, of course, even less than this. And because this is diagnostics, the topic is diagnostics, I had to put this slide in here. And this is basically, I could put it in the end of my presentation, because this is something what we do actually in our clinic. So first of all, children are diagnosed on the primary care level, just by measuring the patient. If they have some additional phenotypic features, they come to our outpatient clinic. Of course, we do a lot of other diagnostics before we take blood for genetics. And one of the things for sure which we found out is very helpful is to determine whether the patient is disproportionate, meaning has short limbs, for example, or proportionate. If they're proportionate, then of course we try to find some endocrine disorders which are associated with short stature. Of course, the most well-known one is growth hormone deficiency, and then we do appropriate tests which are not only genetic, but we can also do some genetics, as you will see later. Then there are some syndromic states where you can just by looking at the patient see some, for example, dysmorphic features, and this can lead you to make the diagnosis. For example, in the case of girls with Turner syndrome, you do karyotype, and of course you have the diagnosis quite early. Or, for example, in Silver Russell syndrome and some other diseases which are mentioned here, you do MIRPA, for example. Then we have some unrecognized syndromes. We were talking about unrecognized causes of short stature. We call it idiopathic short stature. In these cases, we go for more in-depth genetic analysis. And nowadays, we mostly, in children which are very short, we go to whole exome sequencing and whole genome sequencing, as you heard from the previous talks. On the other hand, if the child is disproportionate, of course, we can do first some skeletal surveys. So we do the radiographs of the bones, and we try to find specific syndromic states associated with this disease. And then, of course, we have to confirm this again by genetics. So genetics, in the end, is very important. And as you heard from previous from previous presentations, in the end, you can get really a lot of information. And once you get this information, you have to sit together with basically the geneticist who has done this technical stuff, and talk together whether this fits basically the phenotypic picture you see in the patients. And once we think about this, of course, knowledge of endocrinology is quite important. So this is just a small reminder of what is the most important pathways in endocrinology which are associated with growth. So we can start from growth hormone production in the pituitary gland, and then, of course, by its action on the receptor on the liver, production of the insulin-like growth factors, which together with other factors then actually travel to the growth plate, where growth plate actually is the place where we're growing, where our bones are elongating by the process called endochondral ossification. And on all of these places, we can have basically, on all these levels, we can have some kind of the problems which lead to short stature. And one of the very interesting things that happened 15 years ago was the determination of some of the growth factors within the plate. One of these was called ACAN. You see it here on your left side, or on your right side, sorry, where we actually identified genes which were usually associated just by extreme short stature with extreme skeletal dysplasias, but in the heterozygous states, as I will show you later, are associated with idiopathic short stature, which is much more prevalent. And there are, of course, also some other genes which are associated both by paracrine and intracellular mechanisms leading to the process as I described before. This is endochondral ossification. Now I will show you some of the cases where we, by doing the genetics, also managed to then try to treat these children efficiently. And one of these is actually a historic paper. So from my mentor, Professor Kržišnik, who has actually gone to vacation on the island of Kirk. So it's good for the pediatric endocrinologist to go on vacation. And he, a lot of the time, saw these little people who also had some different other associated complications like hypothyroidism, adrenal insufficiency, hypogonadism, and so forth. And with some of his very quite well-known friends, basically, they discovered that PROP1 mutation was the mutation which was associated with this combined pituitary hormone deficiency. And this is now one of the genes which we look for in these patients. And why this is important? It is important since once we make the diagnosis in a child with short stature that they have this mutation together with, of course, growth hormone deficiency, they can, of course, also have other dysfunctions, as I said before, life-threatening adrenal insufficiency, for example, hypogonadisms, and so forth. So making the genetics on all of these genes now enables us to basically make the diagnosis and also talk to the patient already when they are quite young about how their future is going to look like or what are the things we should look for in the future. And of course, determining the growth hormone deficiency, it's quite nice diagnosis basically, because treatment of these children with growth hormone is very efficient. So once you give the growth hormone, these children basically increase their height, velocity, and they can actually achieve height within their genetic potential basically. Another gene which is quite well described, and it's associated also with short stature together in the Turner syndrome, is the shock gene, which is located on the X chromosome. If you have, let's say, too little of this gene, you're quite short, so you have a very severe skeletal dysplasia. If you have too much of this gene, you're tall, like, for example, in Klinefelter syndrome. And this is, again, one of the genes which was associated with monogenic growth disorders in humans and was looked for. You can apply different techniques, as were already described, from fish analysis, Sanger sequencing, to multiple analysis to determine these basically, these changes. And determination of this gene is important for these patients, since we can then basically, even if they don't have Turner syndrome, if only they have shock gene deletion, we can advise them to use the growth hormone treatment. And growth hormone treatment is quite effective also in these children, as it is effective in the Turner syndrome children. So somebody who actually does not have an indication for growth hormone treatment can benefit from this kind of diagnosis, and we can basically treat them efficiently and we believe also safely. Then, of course, we went for other genes, for example, Noonan syndrome genes. There are a lot of genes associated with Noonan syndrome. It's an autosomal dominant disease. It's relatively frequent. It's not only associated with low growth, but also with other complications. Sometimes they are diagnosed by their heart conditions, that they have specific phenotypic features. And this is basically nowadays one of the indications for also growth hormone treatment. So making the diagnosis of this mutation in one of these genes is important. Most of these, this 11 minutes. I have 20 minutes. 10 minutes, okay. Then we'll skip a lot of the things. Sorry, I thought I had much more time. So yes, Noonan syndrome, and again, we can basically treat these children with growth hormone. So I will skip a few of these slides, and I will go basically to this chart where we look at the ACAN gene. Basically, as I said to you before, it's a gene, if you have it in the heterozygous state, basically you can treat this child. And this is something that we also have done in our study, where we can study it, where we have studied basically 182 children with idiopathic short stature with next generation sequencing. What we found out was quite a lot of cases with ACAN MPR2. Again, these are children which do not have indication for growth hormone treatment. And we actually applied the treatment to these children, and these children really started also to grow. So nowadays, this is something, although it's not an indication for treatment in the moment, is something that we can offer these children as treatment. Another gene which is interesting is the MPR2 gene. Similar story, treatment with growth hormone, although it's not specific treatment, it's efficient. And then we go to the final one, FGF for receptor 3, which is actually associated with hypochondroplasia or achondroplasia, which you all know. It's associated with severely affected endochondral ossification. And in this case, basically, what we can actually see that these children are really short stature. And of course, they have different other features and comorbidities. But nowadays, once we make this diagnosis, they can be treated by specific treatments. So with the treatments which actually affect this pathway and can actually, in studies, achieve basically almost normal height velocity as children without this disease. We are using this treatment for several years also in our country with, let's say, some effect, as you can see on this slide. So to conclude, determining the genetic cause of short stature is greatly facilitated by the modern genetic approaches, as was discussed earlier. Clinical presentations and treatment options range from, as I said, relative deficiency of the growth hormone to the resistance. And this is, of course, important not only from the perspective of treating the patients we already have, but also of the perspective of planning new treatments which would be applied to novel target genes, which will be for sure identified by using these modern genetic approaches also in other children with idiopathic short stature. So thank you very much. Of course, none of this would be possible with the big team, especially the genetic team in our lab, which of course do all the things you have heard before, and then we discuss the outcomes. Thank you very much.